Professor Blaise, thank you very much for coming to Lisbon.
Thank you for the invitation.
And for agreeing to be here today with us. What I'm going to do now is going to put you some questions that were sent to us by our patients and caregivers about CAR T cells.
Sure.
What disorders are already approved for CAR T cell treatment?
In fact, there are so many. The first one and the most important is non-Hodgkin lymphoma, and different form of non-Hodgkin lymphoma is rather aggressive situation with refractory disease, even if now we try to treat this patient earlier, but the approval is really for the patient who have failed other therapies. Second one is acute lymphoblastic leukemia, both for children and for adults, and we are also treated patients with multiple myeloma.
Okay, so those are the three main indications for but maybe in the future we'll see other indications.
Sure, and it's very important to have this vision of the situation, because clearly there are so many clinical trials going on that most probably in the future we will treat patients with other form of leukemia, acute myeloid leukemia, for example, which is very important. Some patients with solid tumors, because I do think that's a real unmet medical need. And there have been some reports recently about autoimmune disease.
If a patient happens to relapse after CAR T cells, is that the end of the line, or is there something else we can offer them?
There are always a possibility of treatment. Of course, it depends on many situations, the status of the patient, the time when he relapses after CAR T cell. But there are possibilities to treat with another CAR T cell that are already been done. There is a possibility to do an allogenic transplantation, which is important, and many other things are also important. For example, in terms of immunotherapy, there have been the development of monoclonal antibody, bispecific monoclonal antibody, which are very potent and can really cure patients and treat patients after relapse after CAR T cells.
Yes, it can be.
Patients have to keep hope. I do think that's very important, because they are in a bad situation, clearly. But years after years, we are doing progresses. So every year that they keep and they have is very important, because even if they relapse, the situation, the time of relapse will not be the same, and probably new treatment will be available.
Do you think that CAR T cells will ever replace bone marrow transplantation?
At the present time, no. I will hope it is the case, because it's important. At the present time, no, for different reasons. For example, if you remember what we have discussed, the main treatment is for non-Hodgkin lymphoma. In transplantation, the main treatment is for acute myeloid leukemia, and there is no available CAR T cell in this situation. And I do think it's at least my philosophy. Not a single treatment will treat all patients. So what is much more important is to have the possibility to use different treatment and to adapt this different treatment to a given patient.
So your main message here is a message of hope.
Sure.
It's, we are on the right path, and patients have every reason to be hopeful. And
it's a long journey, and of course for patients they have not a lot of time, but nevertheless the journey is speeding at the present time. Remember that immunotherapy started back in 1890, so 150 years ago, and the first transplantation was performed in 1956, 70 years ago. First CAR T cell, the idea of CAR T cell was in 1987. So it's a long period of time. Nevertheless, we progress very rapidly, and the future is very important and is probably bright. So hope is the most important word.
Well, thank you very much, Professor
You're
Didier.
very
It
welcome.
was a real pleasure to have you here with us.
Thank you.
And I'm very grateful for the message you left to our community of patients.
Thank you.